Good afternoon and welcome to the McFarland Clinic webinar, Coughs, Colds, and Other Winter Illness Woes. My name is Shelley Jakey. I'm the Marketing and Public Relations Director from McFarland Clinic, and we are glad you are joining us here today. We have a couple of housekeeping items that I want to share with you. Here is our overview of today's presentation, and in a moment I will introduce our physician speakers. A couple of housekeeping items for you to know that we do have the Q&A button on the Zoom webinar, so you can select that at any point in time, key in a question or a comment that you might have. We will reserve time at the end of the presentation to address some of those questions that you may have along the way. A recording of this is being made, and we will have that available. We will send it out to all individuals that registered for the Zoom webinar next week, and we will also be placing it on our McFarland Clinic website so that you can access again or share that with family and friends as well. And last but not least, we do offer a survey at the end of this Zoom webinar for you to fill in some information about this particular webinar, and also share with us what other topics you would like to hear about, learn about through McFarland Clinic webinars. So today's speakers, we have Dr. Jennifer Killion with Ames Adult Medicine and Dr. Angela Olerich with Family Medicine, Webster City, joining us to talk about all these common cold, coughs, and other woes that we have through the winter season. So at this time, I would like to welcome and turn it over to Dr. Angela Olerich, who will be walking us through some of those common illnesses, symptom management, and what we can do to prevent those. So, Dr. Olerich, I will turn it over to you.
Good. Okay. So I'm just going to hit on each one of these topics. Upper respiratory infections, just such a broad overview. So we'll kind of hit on each one, different symptoms, and then later talk about prevention treatment. So first one, common cold. This is just a general term for all sorts of viral strains that circulate throughout the entire year. Usually pretty mild, a week, maybe 10 days, runny nose, cough, sneezing, nasal congestion, pretty much resolves on its own. Flu, when we say flu, we mean influenza. So generally, seasonally, there's influenza A, influenza B. Usually pretty abrupt onset, fevers, chills, runny nose, cough, sore throat. People usually feel pretty miserable for at least the first couple of days. With that one, symptoms can last a week or 2 weeks. You're generally contagious for about 5 to 7 days. Bronchitis, we hear this term a lot, and for us medically, bronchitis is kind of a broad term for like inflammation of the larger upper airways. It doesn't necessarily speak to the cause, doesn't necessarily mean it's bacterial. It generally just presents as like a persistent cough. Most of bronchitis is also viral. For that one, sometimes needs treatment, sometimes doesn't. It's one of those where we say like, hey, if you have fevers for a couple of days, feeling short of breath, getting worse, time to see your doctor. Now, pneumonia is different, where it's actually an infection inside of the lung tissue. With this, usually people have fever, chill, sometimes chest pain or pain with a deep cough, shortness of breath, sputum production. It can be viral or bacterial. We can differentiate it based on lung sounds during your exam or on x-ray. So for instance, kids a lot of times will get like, you'll hear RSV pneumonia. That has a very specific pattern for us on x-ray versus bacterial. There's usually a specific spot that we can see on x-ray or hear on examination. Sinus infections, when our sinus cavities gets inflamed from infection, virus, we get that pain and pressure. Over 90% of the time, that's viral as well. Color drainage doesn't necessarily help us differentiate bacterial or viral. Green drainage doesn't necessarily mean bacterial, but that's another one where if you have fevers over a couple of days, tooth pain, it might be time to see your doctor. Last one, sore throat. So sore throat pretty much is either bacterial or viral. When we say, the sore throat is from inflammation of our mucous membranes from a virus. We call it viral pharyngitis. And then the most common bacterial sore throat cause is strep throat, which we test for and we want to treat because there can be some secondary complications with that. So if we go to the next one and talk about symptom management, alternative options, biggest things are doing things to support your own immune system. So rest, stay hydrated. You can certainly try over-the-counter medications. Tylenol is helpful to reduce a fever if we're getting a fever that's too high. If you have liver issues, you should talk to your doctor at some point about what kind of dosages are appropriate. Anti-inflammatories are also okay, so like Aleve, ibuprofen. That one, we think more about the kidneys. So if you have kidney issues, next time you're in to see your doctor, see how much of that you can appropriately take, or if you can take it at all. Neti pots are nice. They're not very fun to do, but the evidence on them is pretty good. The one thing I always tell people is it kind of, you can always look up how to do it positionally. So sometimes you turn on your side if you've got the biggest issues up here. There's things online of how to lay to most effectively rinse out those sinuses. And the biggest thing there is to not use tap water. I always say use distilled water. It's not as harsh on our membranes. But otherwise, humidifiers, saltwater gargles, warm tea with lemon and honey. Honey is a great natural cough suppressant. Of course, don't give it to any kiddos under 1 for sure. And then for knowing when to seek medical care, basically signs that like, hey, this might be getting more serious, or you could have a secondary complication, high fever, difficulty breathing, chest pain, prolonged cough, or like, we're not getting better, we just keep getting worse. The other thing is if you're somebody who has underlying health conditions of which you know put you at a high risk of complication, heart disease, lung disease, or any immune compromise, you're someone who may be a little bit more likely to get in touch with your doctor as well. That, and I will turn over to Dr. Killion.
Yeah. Dr. Jennifer Killion, our adult medicine physician, will join us now and walk us through some more information on these respiratory. And just a good reminder, if you have questions as we're going along, please feel free to click on that Q&A at the bottom and fill that in, and we'll take those questions at the end. So, Dr. Killion, I'll turn it over to you.
Hey, you can hear me, but I'm having trouble getting my audio to start. There it is. Hi. All right. So we'll talk a little bit about the different illnesses because when we think about what you might have, we often ask what you've been exposed to and how long it's been since you saw that person or since they started to have symptoms if they were in your household. And this is just a few of the things that cause respiratory symptoms that are out there that are pretty common, but there's definitely other viruses that cause colds that we don't have listed here. One of the things that we've been dealing with a lot lately is walking pneumonia, which is mycoplasma, and that actually is a bacterial infection, and it has a really long incubation, 10 days to 4 weeks. So that's a lot longer than the others. Even though it's bacterial, it's usually self-limited and does not necessarily need to be treated with antibiotics. We do have a rapid test for it. Unfortunately, we've had such an increase in those infections recently that we ran out of those. So a good history, and a lot of times you'll see it on an X-ray. It causes a certain type of pneumonia that you see in multiple places. And the reason it's called walking pneumonia is people often walk in, they don't look super sick, and then their X-ray shows these multiple infiltrates. We think a lot of the walking pneumonia that was identified in the past was probably actually viral pneumonias, though, because we didn't have a rapid test until recently. COVID-19 has an has an incubation of 2 to 14 days, and usually it's about 5 days. And so that classic, like 5 days, 5 days, 5 days is what you hear with exposure. And I would say personally, and from what I've seen, that's almost always holds true. Sometimes it's a little earlier. Influenza is one that can hit in about 2 days. So if you saw someone over the weekend, by Tuesday you could be feeling ill, and that would be more likely to be flu. We have rapid tests for influenza and for RSV and for COVID, and those tests are helpful in the first couple of days. For influenza, we do have a treatment for, particularly if you're at risk for severe disease, and we have treatments for COVID-19. We don't have any specific treatments for RSV, but we have a lot of advice to give about it. We actually, right now in Iowa, you can get on the Iowa Department of Public Health website, and you can see what viruses are testing positive. And the number one test positive virus in the past few weeks has been rhinovirus. So we're dealing with the common cold, which has no specific antiviral treatment. So how long will your symptoms last? I put this chart in my office in a place where people can see it while they're waiting to see me, because this is really important. As you can see, the fever should be gone within the first few days, and that's pretty typical of most of the viral illnesses, and actually mycoplasma too. The cough and the nasal obstruction or nasal discharge, you can see at 2 weeks, 10% of people still have those symptoms. And you've probably experienced this where sometimes you get a cold and it lasts 2 days, and sometimes you get a cold and you cough for a month and a half. And there's no real way to predict how it's going to end for you, except those things that Angela talked about. Dr. Olerich talked about getting good rest, taking good care of yourself, scheduling time for yourself to recover. Those things probably do determine some of how severe you become sick with these things and how long your symptoms last. So take good care of yourself when you're sick. The other thing is that the cough and the nasal discharge, they don't get better with no matter what we do most of the time. They just kind of linger on. As long as you're continuing to get a little better all the time, your symptoms will resolve. People come in sometimes after a few days of illness, and they're sure it's bacterial. They're sure this is a bacterial sinusitis, and unfortunately, we will often tell you need to wait 10 to 14 days before we would start antibiotics for a bacterial sinusitis, which is a secondary infection, because most of the time it's really viral. It's really caused by the excess mucus that you're making that's filling up your sinuses. The secondary infections that you get are caused by your own bacteria. And there's not a lot of data that says giving antibiotics for a bacterial sinusitis will make you get better faster. It might shorten your symptoms by about 2 days. And so we do talk to you about that, or at least I try to talk to people about that every time, because there isn't a lot of evidence that the antibiotics will help you get better a lot faster. Time will usually make you get better. Antibiotics do work for bacterial pneumonia. I would say I see bacterial pneumonia pretty regularly, and it's very important for us to identify that. The most common thing we see is a second sickening. So you had a viral illness, and maybe a week to 10 days later, you start getting sick again and you get a fever again, but your cough may or may not be worse. Something's wrong. You're sleeping all the time. These are signs that you might have a secondary infection that we do need to treat with antibiotics. A lot of times we see side effects from antibiotics. We see diarrhea. We see a serious secondary infection from antibiotics with C. diff, and that is very hard to treat. That causes a terrible diarrhea. They don't really help the viruses, and we are dealing with antibiotic resistance, and this is a serious thing. It's a much bigger problem than one person can solve. But we are running out of antibiotics to treat some resistant organisms, and the resistant organisms are traveling slowly through the country, through epidemiological pathways that they do travel through hospitals. And unfortunately, there are people who get infections nowadays with a bacteria that we don't have an antibiotic for. The rate of antibiotic development has not kept up with the rate of antibiotic resistance. So as primary care physicians, it is our responsibility to be careful and conservative with our antibiotic use and make sure that we do give them to the people who need them, but that we're not giving them for viral illnesses whenever possible. So preventative measures. Washing your hands, that's still really important. Avoid close contact, avoid touching your face. We don't have it on here. Don't share food with your toddler. Don't share food with your kids. Your children are often ill from their sharing toys and other things when they're in daycare or they're at school. And that's just an age of your life that you go through like all these different colds and you get them all and you give them to your parents. So if there's kids in your household, wash your hands a lot. Avoid sharing food with them. Don't share drinks with them. It is really hard though. I as a parent, I know I've caught plenty of things for my children. Lifestyle practices, good sleep. That is something I took home from a study I read years ago that found that the single determinant of whether or not it was done among nurses, whether or not these nurses contracted viral respiratory tract infection had to do with how much sleep that they were getting. So schedule yourself adequate rest and sleep. Diet, always, healthy eating, avoid sugars, avoid concentrated sweets, avoid processed foods, eat lots of fresh fruits and vegetables. We have a picture of them right here. Exercising every day is actually really good for your immune system and helps you process all the stuff that comes into your immune system on a daily basis much better. And stress management, which is something that we all try to tell ourselves we're doing, but we might not be as good at it as we like. So give yourself some time to rest and take good care of yourself. She's moving forward. We have vaccines. In adult vaccinations right now, we have influenza vaccines. We have COVID vaccines. We have RSV vaccines. That's a new one that's recommended over age 75 and for people with immunodeficiencies or severe respiratory illnesses such as COPD. And we have tetanus, diphtheria, and pertussis. And we actually have had a whooping cough outbreak recently in our community. We do so periodically, and it's that P in the Tdap that covers that. You should have one of those in adulthood. These vaccines are really important for protecting you, but if you're thinking, well, I'm not going to die of influenza or COVID if I get it, I'm young and healthy, do think about those people who are around you, because part of the reason we get these vaccines is medical providers is we are in regular contact with people who are quite susceptible to flu, COVID, to death from these viruses, RSV. And not all of them are vaccinated. Not all of them have immune systems that respond to vaccines well anymore. The older you are, the less well you respond. And and we want to protect those people by making sure that we are not going to give them something, that we are covered. I didn't in the last slide talk about masking, but masking is really probably important for preventing the spread of an illness, and it's better if the person who is ill is masked. Certainly wearing a mask protects you to some extent, but the protection is greater if you are sick and you are coughing and sneezing. Just wearing that mask actually reduces your transmission quite a lot, especially out in public. Angela, did you want to talk about childhood vaccinations?
Sure, yeah. I was going to say this pretty much echoes yours, but seasonal, flu, COVID, and then Tdap, just in a little different order there. Kids get these at their 2, 4, 6 months. We get a booster at 15 months before kindergarten, and then when they're 11 and 12, just to kind of build up those active antibodies and then put in those memory cells too. But that's really helpful, like you said, just with pertussis on the rise. And then also just like on the pregnant population, the seasonal ones are very important to get as well. So mom can give passive immunity to baby to protect baby, because when they're born, they don't really have an immune system. And then there's a separate RSV vaccine that is different than the one for the elderly and is only for pregnant patients. Again, because RSV is, one of the most common reasons that babies get hospitalized, just for oxygen. That way mom can pass on some immunity to baby as well through the first part of their life.
I did say, we don't have on here measles and varicella, but those are actually childhood respiratory illnesses that are important to vaccinate against. And the vaccines work so good, we don't see those illnesses much anymore.
All right. Well, thank you both, Dr. Olerich and Dr. Killion, for walking us through all these common illnesses that we see this time of year, ways to manage those symptoms, and of course, very important to prevent it. Do want to ask the participants if you have some questions. We're going to move into our question and answer time right now with our physicians. I do have one up here, so I'll just read it out loud, and whichever one of you want to jump in. So how do you get sleep? I think we talked about that. You did, Dr. Killion, in regards to prevention and overcoming these. How do you get sleep when your nose is running and your whole body hurts?
That is a good question. So my advice to people, first of all, schedule yourself adequate rest time, because you might need more. Go to bed earlier, plan that you might need to spend more time working at the sleep thing. We cough to protect ourselves. So we're protecting our airway. We're protecting ourselves from pneumonia when we cough. And things that reduce the cough while we're resting include antihistamines, particularly the sedating antihistamines. The first few nights do help. That's going to be your Benadryl, your doxylamine. And they reduce the amount of secretions that you make. So they take it, you make a ton, and they might take it down a little bit to a point where it's more tolerable. Sleeping upright is important. That changes the way that mucus enters our airway and tends to divert it more into the stomach. And do not sleep with a cough drop in your mouth. I've been tempted to, but that's the cough drops help during the day, but not at night. Cough medications, the data is slim on whether they actually work. You can take some Robitussin. Sometimes just having that cherry syrup in the back of your throat is enough to help suppress your cough for a while. But Angela, would you say that's true in your experience too? Is like everything I read says that they don't work great.
Absolutely. I was going to say, I am exactly on the same page as you. With the antihistamines tend to be the best. I'm like, prop up, get your antihistamines, hydrate, and know that you're not going to probably sleep wonderfully, but the rest time of just giving your body a chance. Those are the big things that I say as well.
Yeah.
Another question that's come in here. Individual says, I've suffered repeated bouts of bronchitis and been treated with steroid inhalers. Is there a limit to how long one should use these inhalers?
That is a great question. Um, so, and I've talked to Jay Brown in allergy about this recently. So it used to be we see a lot of asthma induced by viral illnesses. In fact, a great portion of probably asthma in the United States is started by a viral illness. And it can be very hard to control, and you use steroid inhalers to control that bronchospastic disease that develops, and the inflammation in the lower airway. The allergy people have moved to using it on an as needed basis. So instead of like putting you on it and leaving you on it for years straight, they actually have moved to letting people deprescribe themselves and if they're feeling good, they're not coughing, they're not wheezing, getting themselves off of it, and then they have that inhaler to use whenever another illness strikes, and they might need to use it for a week or two and then be able to be off of it. So over it used to be we would prescribe it for years, and now we're into the thing where you might just need it for a month or two and then you can probably get off.
Okay. Another questions come in. I'm allergic to tetanus shot. How do I protect myself from whooping cough?
As far as I'm aware, there's not an isolated pertussis vaccine. So it's one of those where, like with anything, we try to create kind of a protective bubble around ourselves. So making sure your friends and family can stay up to date on their vaccination, so you have a little bit of immunity surrounding you. And then, like we talked about, wearing a mask, say there's a big outbreak, that's pretty reasonable, even though it's more effective if the sick person wears it.
The good news also on pertussis is we have a treatment for it. It turns out azithromycin will treat it, and we have tests for it. So if you're one of those rare people who cannot have pertussis vaccination, it's okay. We can take care of you. If your allergy was more than 10 years ago, you may want to see allergy and talk about it with them, because some of those allergies actually fade, and they can talk to you about trying a half dose shot in their office and being ready with treatment if you do develop a reaction. And I've had patients who've been able to get that delisted as an allergy and start receiving their regular, every 10-year tetanus vaccine like they're supposed to. The pertussis vaccine, the Tdap, the P part of it, is really only needed once in adulthood, though, as far as I understand currently on the vaccination guidelines.
Okay, very good. Using a finger oximeter, at what oxygen level do you recommend reaching out to your doctor?
Anything below 90, definitely, we would want you to probably just come in. If you're getting in the low 90s, say you're 91 or right at 90, and you're having a lot of distress, you should come in. We do have people who live at 90. That's what their oxygen saturation is. They have often chronic lung disease, and it doesn't bother them much. But there's a steep decline from 90 to 89. And so, yeah, anything in the 80s, we'd want you to come in.
Okay. Another question, is the COVID vaccine going to be just yearly now?
Yes. And so the current recommendation, and it's probably going to sit this way because it sat that way for a while, is anybody over 65 or with immunocompromised condition should get it twice a year. So they're probably every 6 months on them. And everybody else once a year.
How much of a threat is COVID? How do the current prevalence rates look like?
We are in a small lull at the moment. That seems to change pretty quickly. That being said, we still see positive COVID tests. I think it was 4% when I looked at the Iowa Department of Public Health website. Of these tests are coming back positive on a respiratory panel that they do on their samples, which is not a small amount. COVID is still a problem. It still seems to be worse to get the actual disease than it does to be to get the vaccine, as far as our immune systems work and what we see for post-COVID complications. In patients who are immunized against COVID but end up in the hospital even though they've received immunization, one of the things that predicts hospitalization and predicts death is really just the distance you are from your last COVID vaccine. So if your last COVID vaccine was in 2021 and you haven't had COVID since then, you are at great risk if you get COVID now compared to if you've been regularly vaccinated, or even if maybe you had a gap, but you just got the most recent vaccine. Your predicted morbidity and mortality from that virus is lower.
Another question here, how to tell the difference between a cold and COVID without testing?
There is no way. Sorry. Yes. Okay. We do have home tests. They work really well. They tend to take a little longer to test positive. So when you're first having symptoms, if you have a negative test, that doesn't mean you don't have COVID. You should test again a day later.
And I believe there are free COVID tests, right, available through the government in terms of being able to get those for. I know I just recently was on our Medicare webinar and I went back out and signed up to have them delivered to my home. So that might be another resource for folks to have those testing units at home.
Yes. Yeah. So you had them delivered. Can you get them also at the pharmacy for free?
I don't know if you can get them at the pharmacy for free, but that through the government program, it was free.
Through the mail order. Okay.
Yeah, the government will do the mail order ones, or a lot of insurance companies will cover them at the pharmacy, where if you get it at the pharmacy and your insurance covers it, they can run it through your insurance. And I always encourage people, I'm like, have one or two on hand, because you can't tell the difference. For some people, COVID is incredibly mild and no longer is there any like pathognomonic symptoms. You don't lose your smell, or, it's really hard to tell. And it's same thing. There's a lot of early false negatives. Wait a day or two, repeat. Assume you have it, isolate, and then check again.
And at least in our office, if it's my patients and I know them well and they've got a positive COVID test, they call me. I can go through I can call in a prescription for them. It saves them having to come in and see us.
Yep.
And there's a new one that's coming out that tests for influenza too. I'm super excited about that.
Very good. Another person asked, what's the chance of contracting long COVID? We heard about that, obviously, in the early days. What information do we have about long COVID now?
Yeah, in preparation for this, I read a little bit about long COVID, but I did not see the statistics on the chances of getting long COVID if you have COVID. I did see that you're more likely to get it if you've not been vaccinated, or if you're older, female gender, and severity of disease. So if you get a pretty bad case of COVID, that would make sense that you might have a pretty long recovery. And I've seen plenty of people with long COVID.
What's
the definition of long COVID? I mean, what are we defining?
Yes, I read up on this. It's not like there's not like a clear, you fit into this bucket because you have these symptoms after COVID. It seems to be widely varied. Certainly there's fatigue is one of the cornerstones, is just this chronic fatigue that you're tired a lot, but there can be a lot of different symptoms. It can be GI symptoms. It can be generalized weakness. It can be,
Mm.
you know, diarrhea. It can be muscle aches. It can be joint pains. It can be shortness of breath with a normal oxygen saturation. So unfortunately, it's still in the defining phases, but definitely most people have some degree of fatigue.
Okay. Kind of along the lines of with COVID here, a question about the expiration date on COVID test kits. What about the expiration date on COVID test kits? Any information or insights you have on that, either of you?
I'm pretty sure they came out and said that they're basically good as long as they're kept in a reasonable climate. You know, they're not in a super humid, hot area. They're better for longer than what the expiration date says.
Yes,
So people still use it.
I have used expired COVID tests in my household and found only that there might be fewer drops of the little solution. And I would say if there's not enough drops in the solution to put the amount of drops you're supposed to put on the kit, that maybe it's too old to give you an accurate test, because you have to have a certain amount of solution to drop through that filter paper to get the antigen if it's there.
Okay. Couple questions in regards to kind of over-the-counter. Mucinex seems to help suppress the cough, but curious if coughing is good to help remove the phlegm.
So I was going to say the way Mucinex works is more just to kind of like decrease the viscosity of our phlegm, make it a little thinner so you can move it easier. Some people get kind of nausea with it. It's kind of part of its mechanism. It irritates our stomach lining and tells our respiratory system to secrete some more fluid to thin it out. So Mucinex is one. I don't know about you, Dr. Killion, but I kind of go either way. I say, hey, if you feel like it's helps you make that cough more productive to get that phlegm out, great. Otherwise, it's not usually like first in my tool bag to say that it's really going to help a whole lot with your symptoms.
Yeah, I'm the same way. Yeah. I see side effects from it, but I don't see a great benefit. But I have some people who are like, they swear by it. They love the Mucinex. They say it works great. But I know that the data on Mucinex compared to placebo, not great. As far as helping. And back to coughing, yes, coughing at some level is important for us to survive. If we are unable to cough, we get pneumonia and we die. So that cough, though, if you can't sleep because of the cough, if you're throwing up because of the cough, if you can't have a conversation because of the cough, you're probably coughing too much. If you're coughing so much that you're wheezing and you really can't catch your breath, the cough is really just, it's starting to get in the way of your living. And that can happen just because of the airway irritation. So trying to reduce stuff from entering your airway is the number one way to reduce the cough.
Kind of along the same line, do you recommend over-the-counter anti-inflammatory meds to help with bronchial inflammation?
I don't know that I've ever read a study that says that helps.
Yeah, I was going to say, me neither. I don't really have a recommendation on that. I usually say, hey, what helps with your fever or aches more, the ibuprofen or the Tylenol, and which one is safe for you to have depending on your liver and kidney function.
Yeah, that's true.
Okay. Well, right now we're at the end of questions, unless somebody's still typing in. I'll wait here a moment. Want to thank both of you for coming on today and sharing your expertise in this important and timely topic as we head into more of the winter season. Any other points that you would like to make or reiterate before we close out today's session?
I did actually. You had sent me this thing ahead of time, Shelley, about some of the other things to talk about. One of them would be decongestants and their interaction with your blood pressure medicines. I do see that a lot where people come in and their blood pressure is really high and it's that decongestant they're taking. One of the decongestants phenylephrine will probably be removed from the shelves in the near future. It's not really ever shown to be beneficial in studies, and it does cause a lot of side effects. What you'll see with that, though, is the disappearance of anything that has a D on the end of it, which it makes my work a lot easier because I'm always telling people not to take things with a D on the end of them. Don't take Zyrtec D, don't take Claritin D. There is still Sudafed or pseudoephedrine that is available behind the counter, and that is behind the counter because it is used in the manufacture of methamphetamine, and so they try to control its distribution to some extent. That also can raise your blood pressure and also interacts with your blood pressure medicines, and that they're not going to work.
And I think that answers that last question about how to deal with tachycardia from over-the-counter and cold medications. So fast heart rate from the cold medications is directly from the decongestant that Dr. Killion just mentioned.
Okay. I think the other question, can anti-cough meds interact adversely with prescription meds? I guess that's a little different question than actually impacting your blood pressure. Can anti-cough meds interact adversely with prescription meds?
Yeah, so like the Robitussin and stuff like that, probably, but we don't see it as much. I would say back to like the stomach upset and the things you get from the guaifenesin, that can certainly make you feel not better. But in general, what you find a lot in these cough syrups is they contain 3 or 4 ingredients, and one of them is actually that phenylephrine. And especially when you get to your NyQuils and your Dayquils and your things like that. And so you do have to be careful on the cough syrups, and what you're really looking for is the decongestant in there that will interact.
Okay. Dr. Olerich, any other final thoughts that you have before we close out today's session?
Your vaccinations. My biggest thing is always, if you had a test coming up and you could get a preview of it so you could study ahead of time, wouldn't you look at that? Vaccines are the same, giving our body a preview of what's coming, so when we do encounter those things, we are armed and ready. So that prevention goes a long way.
Very good. Well, thank you again to both of you for your time, your expertise to share here today. And as a reminder to everyone, we have been recording this, and so we will provide that to everyone who's registered and also have it on our website. And there will be a survey that's offered afterwards, so you can provide us feedback on today's webinar and also share with us additional health topics that you would be interested in hearing from our experts on. So thank you again, everyone, for attending. Have a great weekend.
Thank you.
Thanks.